Good afternoon, everyone. My name is Jason Callahan. I am the Palliative Care Chaplain at VCU Health, part of the Thomas Palliative Care Group at VCU Massey Cancer Center. And welcome to the VCU History and Health Racial Equity Series, brought to you by the Office of Health Equity. This series includes virtual events and online modules in which we will explore how VCU's complex and troubling history have created and perpetuated disparities for our health system's patients today. We need to understand our history in order to forge a more just and impactful future. Health inequities and the disparate outcomes they produce are deeply rooted in American medicine. And we hope the History and Health program will inspire all of us to think of new ways VCU and VCU Health can help promote the health of all in Richmond and the Commonwealth, improve social determinants of health, and develop exciting opportunities to engage with and learn from the communities that entrust us with their care. We'd like to thank our partners at the Humanities Research Center for their support in producing today's event, which consists of a panel of about 45 minutes, 5 panelists, followed by time for questions. After that, we'll be offering an optional facilitated discussion for processing and peer support until 1:30. We'll be recording up until the discussion time, and the video will be available on the History and Health website. If you would like to further explore today's topic, the companion online learning module is available on the History and Health website. Before leaving Zoom, however, please make sure you complete the very brief electronic survey. And as a brief note, we will also be doing another one next month. That virtual event will be scheduled for November. The topic is race, space, and the power in Richmond. We hope that you can join us there as well. That said, I would like to go ahead and start introducing our panelists. Our first panelist will be the Reverend Benjamin P. Campbell. Reverend Campbell is an Episcopal priest, pastor emeritus of Richmond Hill, and a pastoral associate at St. Paul's Episcopal Church. He's the author of Richmond's Unhealed History, a book on the history of Richmond since before the European settlement. He currently chairs the board of the Greater Richmond Transit Company. He's a longtime member of the Richmond Slave Trail Commission and a founding director of the National Slavery Museum Project in Chaco. For 3 decades, he helped develop nonprofit corporations supporting the Richmond Public Schools, including the Armstrong Leadership Program, the Micah Association, Communities in Schools, and Armstrong Priorities Freshman Academy, the RPS Educational Foundation, and the RPS High School Futures Centers. He served 3 parishes in Richmond and as communications director for the Episcopal Diocese of Virginia. He directed 2 nonprofit corporations, the Richmond Urban Institute and Home Base Incorporated, a neighborhood-based low-income housing corporation. Reverend Campbell, thank you so much. How do we get here?
Gosh, Jason, well, the first thing we do is we cut that bio in about a quarter next time around. You know, I'm not real strong on the 19th century history of MCV. I do know the Egyptian building is a very significant building, was I think in 1840s, and it stands out. So it stands out in the pre-Civil War pictures of Richmond. It was built on a hill above what was known as the Negro Burial Ground. You can guess why it's located where it's located. And, you know, I don't have any data on that. I do think our Slave Well project showed that. The next thing that I know about comes from around 1920 when St. Philip's Hospital and School of Nursing is started. And I learned the other day that although that sounds like a really positive step, and in some ways it was also an attempt to preempt the economic strength of the African-American community that had been building itself strongly in what scholars call the separate city of Jackson Ward. Jim Crow so completely isolated the Black community that it also gave the Black community a chance to do its own thing. And starting with Maggie Walker and the newspapers in Jackson Ward, we began to get a real strong community of its own, which had its own doctors and nurses and educators. And so here you see that kind of initial thing where the majority community, which is in a discriminating posture, nonetheless attempts to co-opt in the name of help the development of the African American community. You could see the mixed kind of plus minus in that kind of action clearly. Clearly based on the assumption of separation and discrimination, which was fully there. My experience directly with VCU MCV starts in 1970 when I come to Churchill, and I know Cheryl can fill in a lot of this as we go forward. But my experience there is there was a viaduct from Churchill directly to the end of Marshall Street, right where Massey Cancer Center is now, and it was a 2-lane road built for a streetcar that people could walk back and forth from Churchill to MCV on. And so in 1970, what I encountered in that first decade was first that MCV was an employer of significance for people who lived in Churchill. Churchill was 95% Black at that point. White gentrification hadn't really started, although I'm certain I helped it by moving in there. And but Churchill was completely redlined, so you couldn't buy property there if you were Black. You could only rent. So it was a lot of rental. It had the 5th highest concentration of public housing of any city in the country, was in the center of Richmond. So MCV was the hospital of necessity for a significant amount of the low-income population, and of course, low income in Virginia meant Black. And what I encountered was people who were working people having to spend an 8-hour day, of course, uncompensated now if you're an hourly employee, sitting and waiting or standing in a clinic at MCV in order to get just basic health care. And that indicated the whole state of healthcare availability in the city. Of course, there was no Richmond Community Hospital at Churchill. Richmond Community Hospital was the Black Physicians Hospital that was attached to Richmond Memorial Hospital on North Side. And the other thing that really hit me during that period of time, there were a couple of other things. One is in dealing with people who were trying to get their credit right and move from housing, I discovered 2 things. First, and this is a complicated issue, but it was clear that MCV was, I won't say doing experimental work with people, but they were doing work with people that had a full kind of question of likely success and the cost been considered probably would not have been done. So, that's a benefit if it works for you, it's a liability if it doesn't. The other fact, though, which was really true, and I was dealing with housing issues, was that virtually every person that we were trying to deal with who was trying to purchase a house in Churchill who was Black had bad credit because of MCV. It's an amazing fact, and we talked to bankers about it. And what that meant was that they would get health care they would not otherwise have gotten at MCV because they needed health care. But on the other hand, MCV knew at the beginning they couldn't pay for it. Meanwhile, as you know, other hospitals were avoiding low-income people as much as possible. So we're talking about MCV being the only place. And so MCV would do pretty near anything that was needed, praise God. But then they would bill people for services they knew the people could not pay. They would then sell the bills at 30% or 40% to collection agencies, and collection agencies would then harass these people for 5, 6, 10 years in order to try to get, I would sit in people's houses and listened to the phone ring from a collection agency trying to collect a bill that MCV had sold. And meanwhile, MCV had gone on and gotten its subsidy from the state and was doing its work just fine, and never expected to collect the money. So it was a strange situation. It certainly had it was something that the white community did not face at all, and dealt with a very dependent situation with regard to medical care. So that's what I've got as a start. I think it's important to note that MCV VCU's situation was not out simply of its own making. It had to do with the whole community's decision that lower income African American people would have this kind of health care. And the other hospitals were either occasionally helpful or until they could move out to the counties and not even have to deal. So there was a sense that this was where it was going to be, and this is how it was going to be, and the capacity, as you can tell from my description, just overwhelmed anything that would have been possible.
Thank you so much for that, Ben.
Mm-hmm.
Our next panelist I'd like to introduce is Cheryl Garland. Cheryl is the Chief of Health Impact at VCU Health System as the Executive Director for VCU Office of Health Equity. Cheryl is responsible for building programs and partnerships to improve the health of populations and communities served by VCU and VCU Health System. Cheryl is the recipient of several awards, including the American College of Healthcare Executives Regents Early Career Healthcare Executive Award, the VCU Presidential Award for Community Multicultural Enrichment, which is an administrator award, a VCU MCV School of Medicine's Dean's Award for Community Service, the YWCA Richmond Outstanding Woman of the Year Award in the field of health science, the VCU Department of Health Administration Alumni of the Year Award, and the first African Baptist Church Community Leaders Award. Cheryl is a fellow in the American College of Healthcare Executives and a member of Sister Fund, an African American woman's giving circle. She serves on the boards of the MCV Foundation, University Health Services Professional Education Programs, Institute for Public Health Innovation, and the Community Foundation for a Greater Richmond. She is part chair of Vizian's Vulnerable Patient Population Network and is currently president of the American Heart Association Mid-Atlantic affiliate. Cheryl, welcome and thank you.
Thank you so much, Jason. I appreciate the opportunity to be a part of this esteemed panel. I just want to share with this group that this month marks 33 years here at VCU Health System for me. And I share this not as a point of celebration, but as a point of reflection, as I did not believe that I would actually reach this milestone in my career. You see, I came to work here out of curiosity, but have remained because of a commitment to make meaningful change wherever possible. I'm a native of Richmond, and I represent multiple generations on both sides of my family of Richmond residents. This is all I've ever known. So here's where the curiosity piece comes into the picture. So as a child growing up in the 60s and the 70s, my parents made the decision that our family would not receive health care at MCV, VCU Health System, as long as we had options, which translated to as long as my father had a job that had health insurance. I was actually born at the Old Richmond Memorial Hospital that Reverend Campbell mentioned because of my father's conviction, and only visited the MCV campus once during my childhood when my grandmother was admitted to the hospital. And then again, as a temp employee working in the finance department my freshman year in college. While I was at VCU's health administration program, I chose this health system for my administrative residency to understand what was so odd. No, let me change that. What was wrong with this place that made it so that my father refused to bring his family here for care? His justification was rooted in the examples that Reverend Campbell mentioned, in the way that his family, he and his family had been treated when they received care here, going back to the 20s, the 30s, the 40s, and the 50s. He told me explicit stories about waiting in the 80 Williams Clinic waiting room. Many of you don't even know where that is. There's an archway that's now on Marshall Street that represents where the 80 Williams Clinic used to be. But he would tell me stories about his mother packing a lunch and riding the bus to bring him to the 80 Williams Clinic and sitting all day long, hoping that they would be seen by someone during that day. And if they weren't seen in the morning, they'd have to go sit out in the courtyard and have lunch because there was no place where they could go eat downtown, and then go back in and wait again in a crowded waiting room. And his words to me, and I will remember them for as long as I live, I refuse to have my children subjected to that level of treatment. So this is where my journey changed and moved me into the commitment component. When I came here to VCU Health System, it was with the idea that, number one, I wanted to understand what was going on within these walls that made it so that people like my father made a decision not to seek care here in an academic medical center here in the heart of our city. But I also made the decision once I got here that I wanted to continuously seek opportunities to change some of the inequities and the systemic policies and procedures that were ingrained in the institution. Something as simple as, we don't give people appointments who come to the 80 Williams Clinic. You just show up, sign up, and hope somebody will see you that day. And this was when I came in the institution in the late 80s, early 90s. What I will share with you is throughout my time working with the ambulatory care clinics, we were able to change at least those policies. But what I have not been able to erase are the embedded memories that many of our current patients and those who were our patients who don't come here anymore, or members of our community, remember about this place. My hope is that the work that we're doing here through the History and Health Initiative will help to heal and address some of those injustices, but more importantly, enlighten our current and our future leaders and providers to ensure that we never repeat any of those unjust practices for anyone. Thank you, Jason, for the opportunity to be a part of this panel.
And thank you as well, Cheryl. Our next panelist is Dr. Mira Pahuja. Mira became passionate about social justice and palliative care working in South Africa with patients living with HIV and extremely drug-resistant TB during her infectious disease training. At VCU, she is course director of the Patient, Physician, and Society Longitudinal course for all first and second year medical students. The course is focused on professional identity, formation, and social medicine, covering topics such as social determinants of health, cultural humility, caring for the dying patient, medical ethics, historical trauma, and systemic racism. In this capacity, she's received the Outstanding Teacher Award for PPS and inducted into the Alpha Omega Alpha Society at VCU. Dr. Pahuja was also appointed to the School of Medicine's first Inclusion Council and has served on the VCU Hospital Ethics Committee since 2018. In the community, Dr. Pahuja serves as board secretary for the Virginia League for Planned Parenthood. Dr. Pahuja, welcome.
Thank you, Jason, and thank you to the other panel members. I'm happy to be here today. Something that Dr. Garland mentioned had me thinking. You mentioned that I was in South Africa, and one of the things that used to bother me so much when I would go see patients in the rural clinic where I was working was that the patients would just show up at 8 o'clock and they would wait there all day to be seen by a doctor, a nurse, a provider, anybody, because it didn't matter their time. And that was not okay with me. Actually, one of the reasons that I pivoted from infectious disease to palliative care was I started asking the questions about quality of life and what was important. And it was that experience for me that really opened my eyes, that, as Dr. Garland said, you don't have to go far. She said it was the 90s, and that baffles my mind, that time people weren't respected for their time. And that's exactly what I saw. You know, I come to this, I appreciate the Reverend's historical lens and Dr. Garland's historical lens. I think that we can't look at medicine today without looking at our history and the history of race and the history of racism in America. And that's what I focus on when I teach that, what are the causes of the social determinants of health? And in order to figure that out, what are the cause of the causes, we have to look at our systems. And so the systems approach to how we look at these health inequities is what I focus on. One of the things that really led me to this work was, you know, as I was studying in undergrad and reading everything I could, and as I worked in Haiti and South Africa, but also did my training in New York City, I read about race as a social construct, and I understood race as a social construct. And yet when I practiced medicine, I practiced race-based medicine, and I used stereotypes based on people's skin color to determine genetic things, make genetic genetic outcomes based on inferences that weren't correct, just based on someone's skin color. And so how did I come to terms with that? And really what I did was I learned about it, and now I teach about it, and I advocate for changes. And we have to look at our own institutions, and we've been talking about VCU and MCV and their history. We have to keep our institutions accountable for these outcomes. And so whether it's saying, as it was changed nationally, I think 2 weeks ago, we took the race-based correction out of the GFR equation, which we saw in our labs, and VCU will make that change when EPIC rolls out, so in December. But we've known about this for a while, and in the meantime, Black patients are not referred for transplant, and Black patients are not referred for specialized kidney care. In the meantime, there are real consequences for our patients, and that's not just with kidney care. There's calculators and algorithms and the way that we racial stereotype in medicine all over medicine that really affect our patients' health outcomes. So we really need to hold our institutions accountable, and we can look to history to tell us, when did we desegregate our hospital? It was interest convergence. We did so because Medicare and Medicaid made it so that we wouldn't get compensated. So we really need to think how we're practicing medicine, make sure we're practicing race-conscious medicine, understanding that racism affects our patients' health. And that is the determinant that we need to focus on a system level, institution level, interpersonal level. And then also look to the overall systems, and that's all policy is health policy. Dr. David Williams says that all policy is health policy, and figure out what is affecting, whether what the Reverend mentioned about Black codes and Jim Crow laws, that has we have evidence about those effects of Jim Crow on patients' health. So we have the evidence, we just need to push for the change. So that's where I'm focused.
Thank you so much, Mira. Our next panelist is Melanie Rouse. Melanie has been with the Virginia Department of Health since September of 2015. She began her career at VDH as the Maternal Mortality Projects Coordinator. She currently serves as the Virginia Maternal Mortality Projects Manager in the Office of the Chief Medical Examiner. In this position, she manages the Virginia Pregnancy Associated Mortality Surveillance System and the Maternal Mortality Database. She also coordinates all activities for the Virginia Maternal Mortality Review Team. Dr. Rouse was instrumental in establishing a partnership between the MMRT and the Virginia Neonatal Perinatal Collaborative to support in the implementation of recommendations made by the MMRT. Dr. Rouse has been named a government expert on addressing the drivers of maternal mortality by the Alliance for Health Policy, and she's an executive committee member for the Virginia Neonatal Perinatal Collaborative and actively participates on the VNPC Data Project Subcommittee. Dr. Rouse also volunteers on the March of Dimes Virginia Maternal and Child Health Committee. Dr. Rouse, welcome and thank you.
Hi, thanks, Jason. I'm excited to be a part of this panel and excited about the work that you all are doing here at VCU. As you said, I am the Maternal Mortality Projects Manager. The team, and I coordinate and manage the Maternal Mortality Review team. We've been around since 2002, and it was established as a partnership between the Virginia Department of Health, Office of the Chief Medical Examiner, and the Office of Family Health Services. Our team is dedicated to the identification of all pregnancy-associated deaths in the Commonwealth and the development of recommendations for interventions in order to reduce the preventable deaths. We're a multidisciplinary group with representatives from academic institutions, behavioral health agencies, hospital associations, state chapters of professional associations, as well as state medical societies and violence prevention agencies. The team collects data on and reviews the deaths of all Virginia residents who were pregnant within a year of their death, regardless of the outcome of the pregnancy or the cause of death. And we call these deaths pregnancy-associated deaths. We also collect records from the hospital where the birth occurred or the pregnancy-related issues occurred. We also collect records from any medical providers that they may have seen. We reach out to social services agencies, mental health facilities. We want to make sure that we get a full comprehensive review of the last 5 years of that woman's life in order to really look at all of the factors that may have contributed to the death. We review these cases to determine any community-related, patient-related, healthcare facility-related, or healthcare provider-related factors that may have contributed to the death. And when we looked at our deaths in the Richmond area, between 2000 and 2015, we've had about 72 pregnancy-associated deaths identified in that area. And of those deaths, 54 were able to be reviewed by our maternal mortality review team. We found that about 52% of the deaths in the Richmond area are actually preventable. And when you break that down by race, it's about 38% for white women and about 60.6% for Black women. We also found that about 26% of these deaths in the Richmond area are related to the pregnancy, with about 19% of deaths among white women being pregnancy related, and about 30% of deaths among Black women being pregnancy related. When we look at the maternal mortality ratio or pregnancy associated death ratios by years between Black and white in the Richmond area, you'll see that it varies from year to year, but overall, the ratio is about 2 to 3 times higher for Black women compared to white women. When we look at the causes of death, you also see some distinction there as well. When we look at the top 5 causes of natural death among Black women, we see things like pulmonary embolism, cardiac conditions, exacerbations of chronic diseases, or cardiomyopathy and disorders of the central nervous system. When we look at white women in the Richmond area, those top natural causes of death were infections, cardiac conditions, cancers, and pulmonary embolism. Most of the deaths among white women in this area were from violent deaths, including suicides, homicides, and accidental overdoses. As I said before, we go through these cases to look at as comprehensive overview of the last 5 years of those women's lives to see what factors may have contributed. And specifically among cases in the Richmond area, we see that 22% of those cases have at least one facility-related factor, and about 41% of the cases have at least one provider-related factor. These facility-related factors include inadequate or unavailable personnel or services, delays in being able to access services, things such as being blown off in the emergency department or poor discharge planning. And when we look at provider factors, one of the biggest factors that we see is the failure to refer or to seek consultations as appropriate, and also an inadequate assessment of risk. And as we're reviewing a lot of these cases, one of the factors that we often see come up and when we're reviewing the medical records is we often see non-compliance as a reason for not seeking treatment as prescribed by providers or things like that. But as we go deeper into the cases and look at the woman's lives, see it's not necessarily non-compliance, it's more unable to comply. So we see a lack of addressing the barriers amongst Black women in the Richmond area. So like I said, I've been doing this work since about 2015, and the more answers we get with the data we have, the more questions we have. And so it's really important that we have these open discussions and really look at the root causes of the disparities that we have.
Thank you so much, Melanie. And our last panelist that I want to introduce is Teresa Riley Tika. Teresa is a former registered nurse, CIS coordinator at the Massey Cancer Center, and public health worker. She's the founder and lead of the African American Breast Cancer Support Group, which she started in 1993 while employed at the Massey Cancer Center. Although retired, she continues to work with the group through Zoom. Teresa, thank you and welcome.
Sure. Can you hear me now?
Sure can.
All right, excellent. Good afternoon, and thank you for inviting me to this event. I will introduce myself by letting you know that I moved to Richmond, Virginia with my husband in 1985. I'm a graduate of Howard University School of Nursing. But I will say that two of my college professors were graduates of MCV School of Nursing. And so two of them gave us some pretty good insight as to how the world actually runs in the field of nursing. So that opened my eyes back then. But at the same time, I was working for F.E. Berry, volunteering for her in the community. And that opened my eyes to some of the needs of communities. I was overwhelmed with the fact that the community just didn't have access to knowledge. And I felt that as I was taught, knowledge is power. And I was really concerned about that. So once I moved to Richmond, Virginia, I started working in the hospitals a little bit part-time. Then I received employment, excuse me, with the health department. I had some really interesting experiences. As I was told, the first Black public health nurse that worked there, but I soon found out that there was a Black older nurse who summoned me to come and speak with her. So with that, I gained some more knowledge, but I found things to be interesting. While I was there, there was a professor at MCV School of Nursing who asked me if I would field nurses from MCV who needed to have introduction into public health, which is what I did. And I found that to be quite delightful in working with students. Meanwhile, while I was at public health, again, I'm looking at the community, the rural communities, Powhatan, Goochland, Chesterfield, and Richmond, and Colonial Heights, and there are pockets of Black people that just did not have information pertaining to health. So one of the things I did was I was successful in getting a grant for 2 years through HHS, and I wanted to address some of those controllable risk factors. And some of those things now, of course, feed into the social determinants to health. And was actually awarded, surprising to me, awarded a second place for developing and evaluating programs related to African Americans and actually weight management. So after that, knowing that I had a strong family history of cancer, I went to work for the CIS at the Massey Cancer Center, and had some very progressive and introductions to folks that were, I would say, influenced me quite a bit. So as a result, in working with the community there and trying to bring people to the community and the community to the hospital to get them to understand why it's important to pre-test and to take care of yourself on a daily basis and so forth. I was contacted by two Black community physicians. They wanted to know why there wasn't a support group for African American women. I'm going, I don't know. So I subsequently developed a couple of modules and established 3 support groups, one in Fredericksburg, one in Southside Virginia, and one, let's see, here in Carytown. As a result, only the one in Carytown survived, and but the other two were outliers. And what happened is that the folks just didn't have the time. But I said I was going to do this because it was needed. So one of the things that I found out is folks were afraid to go to MCV. And I realized they needed some tools. They needed a bag of tools that would help them communicate better with the medical community. So that was developed while I worked with the support group. One of the churches said, "Oh no, you can have your support group here." So that came about. We are still operating. I don't know that there is an end date, but we are meeting by Zoom now. We have covered a lot of territory in the past over 20 years. We have folks that come and go because of various reasons. But I think I still stay committed to the community because I would like to close that gap. Because I think if this is going to be resolved, if there's going to be resiliency, the community will have to, I think the community will need to have folks that will work with them directly to explain to them how they can take care of themselves or communicate with the medical professionals, because there are medical professionals that have been pretty cruel to some of my clients, some of my members, including myself. I mean, I've experienced that as well, working in the system and working outside the system. So I think it's important that the community is kept in the loop to a larger degree. And I think that in itself may help some of the community members to understand the importance of hope, working with medical professionals, how to communicate with them, how to look at research as being a possible way of reducing the disparities of health. I think the more they communicate with professional teams and see them, they can sort of reduce the barriers and pass things on, pass the good news on. They just need help in navigating the system. Thank you.
Thank you so much, Teresa. And I see now that we're gonna actually open it up for some question and answers. And we already have one question. I believe Cheryl has already addressed that. Cheryl, would you mind expanding for the folks on the Zoom call? The question is, those of us with insurance know that when we receive medical care, the charges are steeply discounted. Yet even after adjusting for ability to pay, health providers, including MCV, have in the past billed some uninsured patients more than they would accept from Medicare or other insurers. Does this practice persist? If so, can anything be done about this practice that shadows low-income families with that? I know Ben kind of addressed it as well a little bit, but Cheryl?
Sure. Thank you for that question. This has been a long-standing concern and an issue, especially for the uninsured who did not have a lot of options in regards to healthcare. So what has happened here, it's actually since the late 60s, early 70s, VCU participates in the state's indigent care program along with UVA. And patients who are uninsured go through a financial screening process, and our institution receives a combination of state and federal dollars that are available through what's called the Indigent Care Fund or Indigent Care Program. And so individuals who qualify can have up to 100% of their bill written off if they're eligible. With the passage of Medicaid expansion, couple of years ago here in Virginia, or actually in early 2020, We've now been able to engage more people in Medicaid. And so our financial counselors will also screen for Medicaid. So many folks who were dependent upon the indigent care program can qualify. And many are also eligible for the health insurance exchanges or marketplace plans. And so our financial counselors can assist, and their job is to find anything and everything that folks qualify for. And if they do not qualify for anything and remain in a self-pay category, we have a self-pay discount that is applied to the bill. And the discount has been set so that it aligns with many of the payer contracts that we have in place, so that we don't have this inequity that exists whereby people are paying more than an insurance company would pay the health system for the services. And for those who have historically found themselves in the situations that Reverend Campbell mentioned related to bankruptcy or intensive collection practices, over the last couple of years, the institution has modified its policies. Our goal is to never have anyone encounter bankruptcy because of their healthcare bill here. And so our teams work very hard to try and set up payment plans and modules so that folks can avoid that financial disaster and negative impact to their credit.
Thank you, Cheryl.
Welcome.
So Jason, I just wish Cheryl Garland were running every single department and delivering in every situation, because I know she has been just rigorous on working at this for years. I'm going back to the data I had in the 70s. I mean, it was the bankers that I talked to about mortgage payments said that of the people with bad credit that were being disqualified from mortgages, 60 to 80% were dealing with hospital bills from MCV in the center of Richmond. That's how bad it was. So, but I do want to look at some of the continuing issues here. And one is just the complicatedness of access to healthcare for everybody. This is a conversation I had with some folks not too long ago about, and these are people who are middle-class people looking for healthcare. The discussion was about that political statement where they say, golly, if this program in the federal government is approved, you won't be able to choose your own physician. And the conversation was people looking at one another and saying, I can hardly choose my own physician now. It's hard enough to find a physician, much less find one who will deal with me or that I have access to. The medical system is extremely complicated in terms of access for everybody. And if you add to that the fact that you may not have much money, or your skin may be a different color, or you may be in some sense, or you may not have physical access to doctors, which is increasingly difficult because, as we know, the private practices are not locating in the center city. It becomes extremely complicated. So just the question of who helps people or how people gain access in any case to medical care is a problem before you add additional issues of income and race.
Thank you, Cheryl and Ben. Our next question comes from administration. Dr. Kellerman has a question, actually. VCU Health has made substantial strides, but we have more to do. What priorities do the panelists think should be at the top of our list? And I'll give everybody an opportunity to kind of state theirs, all of our panelists. And Cheryl, we'll start with you.
So Jason, it's kind of unfair to start with me. So Dr. Kellerman and I talk about this on almost a daily basis. I do think that there are multiple opportunities. One goes back to something that Reverend Campbell mentioned, which is helping individuals to navigate through the complex healthcare delivery system. And across our organization, we are implementing models where we have outreach workers, community health workers, patient navigators who are working to assist individuals. I think another area that is really important for us to think about is educating our team members, our providers, our staff in general about our history, as Teresa mentioned, and the need to think about how people are managing all of the issues that they have in their life while they are trying to manage their healthcare issues. And so it's important for us who work in the healthcare system to expand our level of compassion and understanding beyond the care that's being provided, to also think about all of the circumstances, all of the situations, all of the issues that individuals are dealing with on a daily basis. And some of them are as fundamental as, will I have housing tomorrow? Will I have anything to eat next week? Will my utilities be turned off? And these not only create additional stress for people who are dealing with healthcare issues, but they also impact health outcomes.
Cheryl. Others?
I'll give you some things. Oh, go ahead. Excuse me.
Oh, no, go ahead. Go ahead, Reverend.
All right. Well, I have a couple of very specific suggestions to you. Put a clinic at MLK Middle School and a clinic at Armstrong. Staff them regularly, and you'll have not only a good teaching opportunity for your students, but in fact, you will provide entry-level health care to a large portion of the community that does not find it easy to get. And if you need a principal's name to call, I'll be glad to give them to you. Second, stop building facilities outside the bus line unless you get the locality to provide bus service. You combined with Sheltering Arms and moved your clinic or your service for people with severe physical issues out beyond the bus line into Goochland County. It is not accessible by bus either for employees or for the families of persons who are living there. You moved a large clinic dealing with a number of other things out in the kind of backwaters of Short Pump, so far from a highway that it can't be reached easily. You did it without any public transportation. Now there's a bus out there, but it's still pretty hard to get to that facility from the road. These things are not minor. They are major, and they are acts of extreme irresponsibility on the part of a decision-making organization that is supposed to be accessible to the entire population. I'll help you get the bus service too if you want.
Thank you, Ben. Teresa, I know you had something.
Sure. I'm going to go back to communication because I think that's something that can help build resiliency in the community, a stronger resiliency. I think sometimes when staff talk to clients and they use terms of endearment, case in point, I was visiting someone who clearly was in the latter stage of life and was pretty miserable. And the staff kept calling the person, and the person was in her 90s, referred to as sweetie, honey, dear. I was always taught, of course, by the older nurses who wore very stiff dresses, that you never call a client out of their name. You always refer them as Miss, Mrs., Miss, Ma'am, Sir, something of that sort. And clearly I had to step in and help this person. And it's interesting to me how folks of various cultures feel very comfortable calling us an older person, sweetie, honey, hon, dearie, that sort of a thing. And in some cultures, we know you're not to disrespect elders, but why when you see a Black patient who is clearly suffering and is miserable, you call them that? I actually had to step in and say, please do not call her this. She's old enough to be your great grandmother. Okay, so that's one piece on the communication. The other thing is, I've had someone say, all right, why do we have to learn about other cultures? This is America. And this is just a few years back. That startled the heck out of me. If it was someone young, I clearly had to lean in and say something. So I think communication is a big issue. So when I work with communities, and I've done things in prostate cancer and breast cancer and some other issues, and I explain to people how data is collected and how it's 2 years behind. I've explained to people how you communicate with someone. If they want to call you out of your name, this, these are the things that you say. I think also another case that resonates with me is a client went to be treated and medical students were brought in without asking the person, do you mind if we bring in some medical students? And when the person raised the question, the response wasn't something I would have said to the patient. On another occasion, the patient went in and was going to be examined, I guess a follow-up for a breast exam or breast cancer, following breast cancer treatment. And the patient was told to shh by the medical staff. Now, what's interesting is she said to me, and by the way, they were examining the incorrect breast. Well, the person decided, okay, you know what? I'm not coming back here. So I personally have situations like that. I'm not coming back either. So I think, whether it's implicit or explicit bias, or whether it's what you call cognitive dissonance, those are maybe some of the terminology that has to be addressed when you're working with people in the medical environment. They may knowingly, unknowingly, or because they are dedicated to a certain cause or to a certain train of thought that is a result of their environment, understand long-term, this could have a negative effect on somebody else's health. And that's if you really care. And I recognize that healthcare is a business, but it's costly, not only in lives, but also in money, as previously referred to. I just have this thing about how you address people, how you talk to people, so that they can get the most out of it. I had a very good experience once when I was called to come with one of the folks that's in my support group. And I was asked to please to come in with her so that she can understand what's going on. Well, I've always had my instructed people to please write down your questions and your concerns. So when you go in, you're ready to talk to the doctor or the nurse practitioner or the PA. I said, so that they would know you mean business. Okay. And I was taken back by where the patient was spoken to. And I kept saying, whoa, 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 hold on a second. And the client was trying not to understand that she was, near the end of her life and that there was nothing else could be done. So I had to work with on that end too. But, on one hand, I understand, on the other hand, I think there's just work that has just got to be done working with community and working with community people. So I applaud you all for doing this, having this Zoom call or this education session, but also with some of the physicians at MCV who I've actually worked with, who actually understand the need. So those are my comments right now.
Thank you so much, Teresa. Mira.
Oh, sorry. I really appreciate Teresa's comments. And to piggyback on what she and Dr. Garland said, cultural humility is of the utmost importance, and understanding that our patients' context matters, their historical context, what, MCV's history, America's history, it matters to the healthcare they're receiving today. There's many ways that we practice contemporaneous racism in medicine, whether that's our carceral system or just unequal health that we provide. I think from an institutional perspective, I mentioned practicing race-conscious medicine. And as Dr. Garland pointed out, that starts with education of our providers, and that has to come from leadership saying, we prioritize this, whether it's going to some, education that's already out there or building our own like you're doing now, prioritizing it so that all the providers understand the history of racism in medicine and how we perpetuate that. It's not just slavery, it's not just Tuskegee, it's ongoing. And in order to become trustworthy so that patients come to us, and as Teresa mentioned, calling them ma'am or sir and understanding that cultural value and perspective is only going to make the outcomes better if we do that. So we need to look at our own institutions, one, education, to how we individuate care, but also look at our practices. We have reams of data about the social determinants of health supporting that they are there and that there is a difference in outcomes, and we need to figure out why. So the Brigham did a really great study where they looked at their cardiology service. And we know within cardiology that Black patients have higher rates of readmission with heart failure and poorer heart failure outcomes. And the Brigham said, well, why is that? And the smart residents noticed, when I'm on the hospital service, that's a general medical service, I noticed that a lot of the heart failure patients are Black. And when I'm on the cardiology service, that's a specialized heart service, a lot of the heart failure patients are white. And so what they found in this study was that patients who were put on the cardiology service, whether they were Black or white, actually had the same health outcomes. So if you actually, as a Black patient, got put on that cardiology service, you had the same readmission rates as the white patient, and you had the same rates of follow-up with a cardiologist and possibly the same outcomes. But when you were put on a different service where you did, and just a general medical service where you didn't have a cardiologist being aggressive about your heart care, well, of course you didn't have good outcomes. And so why was that? Was it our bias and interpersonal racism that played out and who got admitted to the services? Yes. Was it partly structural? Yes. Who's empowered in the ER to say, you know what, I deserve to be on the cardiologist service. I want Dr. So-and-so, that's my friend. Who's empowered and who is able to participate in their care? So that comes back to the community and really educating our community. So it's okay to look at our own practices and find something like, oh, this is something we can improve on, and talk about it, because they are improving on it and they're going to change their outcomes and their patients are going to be better off for it. So from an institutional perspective, in addition to what Reverend Campbell recommended about where our clinics are located, I think that looking at our practices really makes sense, and will actually improve outcomes and probably save dollars. So that's where I would start.
Thank you, Mira. Melanie, did you have anything to follow up with?
Yeah, I agree with everything that everyone else has said. One of the things that, when that question was asked, that first brought to my mind was the CDC's Hear Her campaign. And it's all about really actively listening to understand women and their perspective in their treatment plans. And I think that's definitely a high priority, because when we look at a lot of health disparities and health outcomes and talk to people, one thing we constantly hear is that they didn't listen. They brushed me off. And so I think it's really important that we put the focus on listening to understand patients, and being able to see the whole person and not just the medical issue you're addressing at that moment.
Thank you so much. And I think we had a raised hand from Eric Allen. Is Eric still in the room? No. That's okay. We'll kind of move on from that a little bit. So there is another question. Teresa, could you share some of the strategies you've tried with your support group members in an attempt to make them more self-sufficient when managing their own healthcare and dealing with healthcare providers?
Sure. Some of the things that we have done, I've brought in guest speakers. I assessed some knowledge levels of the group in the beginning and continue to do that. But I always ask them, what are they really interested in? What are they having problems with? We identify speakers. We've also gone as a group to different activities around breast cancer. So when, for instance, if I received information about an activity, well, now of course it's basically on Zoom or the internet, I have a mailing list, so I will get the information out to everyone, and I will call very specific people sometimes and say, I think this is something for you. I work with various hospitals and bring in speakers, like we've done lymphedema. We're now looking to bring in someone to talk about this, the pandemic and isolation. How do you stay healthy? How do you keep moving? How do you keep eating well? We also talk about attitudes, beliefs, and knowledge about various topics, how political situation can impact your health, and what are some of the things you got to keep doing. And if you're going to vote for someone, you look at these certain categories in terms of what how they think and how you think they're going to vote. We've had some speakers from MCV to come in on Zoom and give us information, just talk about programs that they have. So, education is key to knowledge and to be able to navigate the system. So those kinds of things. And then when the pandemic wasn't around, we would meet once a year and break bread together in certain places. But I do a newsletter quarterly, although I'm a little behind right now. So it varies. I try to we also have activities that keep you aware of yourself, like, for instance, ask folks to identify 6 words that describe themselves, and then write not more than a 3-page essay about it, so we can learn something about each other. They learn things about themselves. I'll send out puzzles or word scrabbles, different things like that. It just depends. And then sometimes they have ideas themselves about what we could do. So just to keep people active, I always send out information about articles and research. We had a big 2-month update on COVID and why they need to get these shots, why they need to get the vaccine. So it's, it's big time. We just do things that are educational